worldwide and in Egypt, Professor Rabab Gafar, Professor of Medical Oncology, National Cancer Institute, Cairo, who will give us highlights on what happened in San Antonio, update on metastatic cancer, San Antonio 2013. Please, Dr. Rabab.
Thank you very much, Dr. Yasser. First, I would like to thank the organizers, and specifically Dr. Hisham Al-Ghazali and his team for this excellent work. My agenda now is somewhat busy about the San Antonio meeting, the metastatic breast cancer. We're going to deal first with the hormone receptor positive, HER2 negative, and then HER2 positive in metastatic breast cancer, what is new, and then chemotherapy in metastatic breast cancer and the role of angiogenic drugs recently, and targeted therapy according to genome profile. From the NCCN, you find this chart for to determine the sites and the extent of the disease for the management of the postmenopausal ER positive in metastatic breast cancer. We have to consider the symptoms, we have to consider the biology of the disease, and of course the pattern of the disease. So if the disease is no life-threatening and hormone responsive, we will go for first-line hormone therapy, and this will happen as a first-line, second-line, probably third-line. And if hormone unresponsive or life-threatening disease, we will go directly to chemotherapy. But mind you that in hormone-responsive, no life-threatening disease, when you go for hormonal therapy, the first line, the progression-free survival is usually with a median of 10 to 15 months, and the second line is about 3 to 4 months, and we struggle to work on it. What about endocrine therapy for metastatic breast cancer in hormone receptor positive, HER2 negative? Now, to reverse the resistance of hormonal therapy, there are many ways to do it, and the first one is to combine endocrinal therapy together. And for endocrinal therapy, we have the fulvestrant studies like the FACT trial comparing anastrozole versus anastrozole plus fulvestrant for first-line metastatic therapy in hormone-responsive postmenopausal cases. And you see here that the results of the FACT trial proves that the time to progression and overall survival were exactly the same for both the anastrozole or the combination therapy of anastrozole and fulvestrant. Mind you, the dose here was the previous dose using the 250 milligram and not the one in the confirmed study using the 500. Again, the SWOG trial comparing anastrozole to anastrozole plus fulvestrant, and here also in postmenopausal cases as a first-line therapy. And you see from this trial that this was somewhat different, and you can find some difference between the cases of the combination chemotherapy versus the single hormonal therapy with regard to progression-free survival and median overall survival on a whole. Why? We tried to find why is this difference, and this is from the last San Antonio meeting. Dr. Johnson said that there were differences between the two studies, the FACT trial and the SWOG 0226 study, and this shows that the de novo metastatic disease was more in the SWOG trial. The prior adjuvant chemotherapy was less in the SWOG trial. Prior adjuvant endocrine therapy also was less in the SWOG trial. So the median or the mean progression-free survival was 10 to 11 months in the FACT trial and 13 to 15 months in the SWOG trial, proving that maybe if the case is completely naive to endocrine therapy, combination therapy with fulvestrant and anastrozole may be better. Then came the SOPHIA trial. SOPHIA trial was done in the UK for also fulvestrant anastrozole versus fulvestrant and versus exemestane, and the results have shown that whether you use exemestane or you use anastrozole, there was no difference for the combination versus any one of them. Again, this was a second-line therapy, and mostly for the sensitive endocrine cases, so neither for the first line or for the sensitive second line, there was a difference. And mind you, again, this was 250 milligram of fulvestrant compared to the confirmed trial that we all know about it, using the 500 milligram and proving that there is a difference. And this is why there are now trials comparing just anastrozole to fulvestrant in this dose. Now, struggling to reverse the resistance again, there is a combination of aromatase inhibitors and targeted therapy. And the most well-known trial is the Bolero trial. And the Bolero 2 study, here is the mechanism of hormonal resistance, and you see the crosstalk between the ER positive and the growth factors, and increased signaling through the EGFR or the growth factors, so increasing signaling through the PI3K pathway. This also the crosstalk. So Bolero 2 trial have showed that there is definitely a big progression in the progression-free survival, and as you see, the difference is present and p-value is significant. Not only that, but also for the overall survival, you are comparing 4 months to 11 months of survival. So this is very substantial, and it was very effective therapy and a new way approved. On the contrary, the Horizon study, which is also an mTOR inhibitor, not like the everolimus, a different one. Now, when letrozole was combined with sirolimus versus letrozole alone, you will find there was no difference with regard to progression-free survival or overall survival. And why? This is the difference between the Bolero 2 trial and the Horizon study, but you will see that there are some caveats. As I said, the two drugs are not the same, and the difference is very well present in front of you, that the Bolero 2, the median progression-free survival for the cases, control cases that did not receive the everolimus was just 4 months, while in the Horizon study it was like 10 months, meaning that maybe in the Horizon study it was early cases, so that they were very responsive to the hormonal therapy, and you cannot add much for these cases. Again, when they tried to find the same for the Bolero study, as early cases failing after adjuvant therapy and receiving hormonal therapy and everolimus as first line, they still found it was of value. So combining targeted therapy and hormone therapy is not only to block the mTOR to find these results. There are many, many other targeted substantial intracellular that you can block to find a response. And this is what happened, and this is what was under development, like the PI3K pathway, FGFR, the CDK4/6, and the PAN-HER. This is MINT study. A MINT study is a phase 2 randomized, double-blind, placebo-controlled, multi-center study using something known as AZD8931, which is a PAN-HER drug. Combining it with anastrozole versus placebo and anastrozole as a targeted therapy that may block and reverse the response to hormonal therapy, and the result of the main study was not in favor of using targeted therapy with the anastrozole. As you see, the anastrozole may be better than the combination with the targeted therapy. This was also the case for the insulin growth factor receptor drug, which is janitumab, and janitumab is a very recent drug that was combined with exemestane versus fulvestrant or versus exemestane. And in this case, there were no difference for the cases as regard the progression-free survival or overall survival for the exemestane or the fulvestrant in comparison to the combination. Again, this is the SARC family, and how SARC is used also to block this intracellular cascade or component. So the new drug is in breast cancer is dasatinib, and dasatinib was used in combination with endocrine therapy for the ER-positive metastatic breast cancer following the progression of non-steroidal aromatase inhibitors. And you see also from this trial, these are disappointing trials proving that the addition of dasatinib to fulvestrant or exemestane did not work. On the contrary, a new study proving that letrozole with dasatinib versus letrozole showed a clinical benefit rate and progression-free survival difference, but they said that here the hazard ratio of 0.69 was exploratory and needs further explanation. This is a very important slide showing that the FDA designates in oncology breakthrough drugs. And these breakthrough drugs, if you look to the breast cancer, they specified antinostat and they specified palbociclib, where antinostat is an HDAC inhibitor and palbociclib is a CDK4 inhibitor. This came from the two trials. The first one is the ENCORE 301 trial, which is a phase 2 trial comparing exemestane plus minus antinostat in ER-positive metastatic breast cancer progressing after non-steroidal aromatase inhibitor. And if you look here, you see that the addition of antinostat to the exemestane, although there were no promising effect for the progression-free survival, yet for the overall survival, you have like 10 months difference between the cases that received the combination versus those that have received only the exemestane. What about the CDK? We know that the CDK is a group now of drugs for, it inhibits the passage from the G1 to the S phase, blocking the cell and preventing growth. This is targeting the cell cycle, CDK4/6, and how it works. So this is a trial using letrozole with a new drug that is from the group of the CDK4/6, and proving also that there is a progression-free survival definitely of difference between using the combination versus using the hormone therapy with a highly significant p-value and a median progression-free survival of 26 months for the combination versus 7.5 months for letrozole. And there are now randomized free trials using these CDK4/6 inhibitors and also the HDAC inhibitors. So the highlights for metastatic breast cancer implications for routine clinical practice from the last San Antonio meeting for the hormone receptor positive metastatic breast cancer is that at progression of non-steroidal aromatase inhibitor, there is a modest response to further endocrine therapy, no benefit for combined fulvestrant and aromatase inhibitor.